morning, Dr. Kruse.
Good morning.
Based on the totality of your testing, in its whole, you found that Tim was not malingering, right?
That's incorrect.
When you and I met before to talk about this, right?
We did.
And we talked about how the totality of your testing indicated that he was not malingering. You would have made a diagnosis of malingering, right?
So I did a diagnostic conceptualization at the end. I did not I discussed malingering in terms of the behavior. In terms of the cognitive aspect of his functioning, he did not attempt to present himself in a negative way. And so I'm very careful about the way I write things in my reports. And so in other cases where I might list out diagnoses, if I'm the sole evaluator, in this case, I was providing assistance to Dr. Frierson with my data. So he was the one that formulated the diagnoses. And so when you and I had spoken, I said, I mean, not only did I not list anything in a line like we do with diagnoses, I mean, I didn't list personality disorder, I didn't list substance-induced psychosis, but I did describe everything in a paragraph.
Right.
Does that clarify your question?
I'm not sure because, Dr. Frierson said that he did not diagnose Tim with malingering, which I assume would be based
Objection, that's mischaracterization.
on.
He said what he did was...
No, let's don't argue. Rephrase your question, consistent with her report, I guess. Rephrase your question to make it clear. I think she may have been unclear.
I'm not trying to trick you.
I understand.
But are you aware that Dr. Frierson said that he did not diagnose him with malingering?
Objection, that is absolutely
That's
not
exactly what he testified.
Now you're doing it. Stop. Come over here.
Dr. Kruse, you saw Dr. Frierson's testimony in this case, right?
What was the question?
No.
Just whether Dr. Kruse saw Dr. Frierson's testimony in this case.
I did not have the opportunity to observe the entire testimony.
Thank you. Regarding Dr. Brawley's report that you reviewed, right?
Yes, I think I had the summary of her report, correct.
And she was the one that determined him to have an IQ of, what was it, 87?
Correct.
But in her report, she says that she thinks that because of his medication, right?
She said that was a factor, but not entirely due to his medication was his IQ suppressed.
But she surmised or guessed that his IQ was substantially higher.
Yes, correct.
She thought maybe around 120 or something, right?
Correct.
Just want to, before I ask you a little bit more about the tests, I just wanted to ask you a couple things about some of the things that you discussed with the solicitor regarding brain injury and neurocognitive disorder. And you talked about how the brain can regenerate after an injury, right?
Correct.
And that's what I think you referred to as plasticity.
Neuroplasticity, correct.
Plasticity. But that is made more difficult if a person sustains two brain injuries in the same place, right?
So succinct or successive concussions or brain injuries are known to have exacerbatory impact, yes. In terms
of worse, right?
Yes, you're less likely to recover as well as you did the first time.
Right.
Mm-hmm.
And regarding the fact that a brain injury doesn't necessarily cause a cognitive problem, you I'm sure, are aware of the case of Phineas Gage from the 1840s. Right?
I am.
Can you just tell us about that?
Yep. So that's example we commonly use in teaching with residents or with any type of student. It's someone who had a trauma, a significant trauma. I believe it's a railroad bar went through his, the frontal lobe and out of his head, actually. He did survive the accident, but his personality changed drastically.
And it was a steel bar about this tall, wasn't it?
The pictures, as we use the word impressive, were impressive. It wasn't like this. It was very large, correct?
It entered underneath his right eye, right?
Yep, and out through the other end of his skull.
Came out top of his skull.
Correct.
This was in I think 1840.
I don't remember the history of it, but yes, it was a while ago.
Because he worked on the railroad, and there was an explosion that caused that to happen.
Yes.
And I think that, amazingly enough, he was back at work within a week or 2 weeks, something very short after the injury.
Correct.
And he was still just as good at his job when he was after the injury as he was before, right?
I don't remember the exact details, but right, he was able to perform his job. I remember that.
But he was a different person.
The teachings of the case are in regard to personality,
Right.
Drastic change, difference in personality for this case in particular you're speaking about.
So, I mean, he sustained a massive brain injury, but it didn't affect him cognitively, meaning intellectually, he was still put together, right?
I don't know if put together is not a term that I can use in terms of data. I don't know about any data discrepancies with him. I don't know about any IQ testing that was performed. Right. But what you're saying in general is correct. He was able to return back to his work, and the main teaching of the case was that the main symptom everyone observed was the personality change in this individual because of that injury.
Thank you. I just want to ask you a little bit about how these tests are scored and how the reports are generated. And I'm not entirely sure about it because I'm just trying to figure it out on my own. But is it correct that with some of these tests, you ask a series of questions, or the patient is asked a series of questions? Is that right?
Correct.
And a lot of them are multiple choice or true or false.
In the personality ones, right? Some of them, correct. Mm-hmm.
And then the data are just the person's answers to the questions, right?
In some of the tests, correct.
Yeah, and I'm talking about the personality testing. Is that right?
There are some personality tests that are entirely different, but in the ones I administered, you're correct. These were, right, the paper and pencil, true, false type questions.
Right. So that's the data that you then put into a system to generate a report. Is that right?
Correct.
Okay. And is that what you did in these cases? In the test that you gave Tim, you took the data and you put it into a program that you have accessible to you because of your profession. Is that right?
In the 3 personality tests I administered, yes, those were scored in that manner.
Okay. And so the report that gets printed out, it looks like a report that somebody actually sat down and typed up, right? I mean, it's several pages that analyze the data that's just put into the system. Is that right?
No.
How does that report get you?
So,
not your report, but the computer-generated report. How does that get created?
So in some cases, you can have reports generated that do some degree of interpretation. Other times, you can just have the profiles, which that's the part I rely on. In this case, I believe one of them came with some type of interpretation, but that's the computer just kind of spitting out what it would for anyone scoring in those areas. But the other 2 specifically, the MMPI and MCMI, I utilize the T scores or standardized scores. I can show you, but it's a kind of peaks and valleys. So it looks like if you had an EKG, what you would see go across the screen. That's how I interpret the data. So I don't rely on the computer because it's not a doctor.
Right, I understand.
Right, I know you do.
It struck me as a little bit weird too. You would just have a report generated by putting in a bunch of scores. But you did use the computer generated report to inform your final report that you submitted in this case for the PAI protocol.
I don't read whatever the computer, I think it automatically prints it out. I mean, that's not what, I'm using the actual data sets, and I extrapolate my opinion based on if something meets a threshold or exceeds a threshold of clinical significance in terms of the T-score generated. I think, it's helpful for graduate students or people who, psychometrists maybe, to gain a better understanding of the test, but you would never interpret a patient's or conceptualize a patient based on what a computer is saying.
Yeah, I would hope not.
Right.
But you had the computer generated report made based on Tim's answers for the PAI protocol, and you provided that as part of the raw data.
If I did, then I did, yes. Yeah, I made sure I sent everything I had to you all.
And the report that you submitted to the court for purposes of what's your analysis, your report, it has sections in it that are verbatim from the computer generated report. I assume that sometimes you copy and paste sections from the computer generated report into your report because you think that it makes sense.
If it's something relevant to the diagnosis, yes, there's certain ways we say things that are very stereotypical, if you will.
And do you have a copy of your report up there, or do you need to have one here for you?
I have a copy.
And I just want to talk about the part of your report on PAI. That's all right. I believe it's on page 8. Yeah. And that the paragraph that begins in the middle there, it starts with the PAI protocol,
Yes.
and then the paragraph below that, it begins with despite the level. See that paragraph?
I do.
Those two paragraphs are essentially verbatim from the computer generated report that you had made based on Tim's testing. Is that right?
If they were things I thought were relevant that met my interpretation, that is what I would use, yes.
And that's just because you found that those two paragraphs from the computer generated report substantiated what you thought.
Not substantiated what I thought, but were relevant to the conceptualization or what I gathered from the instrument.
Right, and they supported what your opinion was.
So are you inferring I'm taking pieces of the report to meet my?
No.
I'm not sure what you're. I'm not.
No,
I want to make it clear.
That part of the computer generated report you found to be representative of the testing.
Well, any of the computer part would be. I mean, anything that is being extrapolated from the data, it will summarize.
Right. So anything in the computer generated report would be representative of what the data says.
Right.
And that's because the computer is just reading the data.
Right.
And the data is just the person's answers, right?
Correct.
But if you look at the two paragraphs from your report that are verbatim taken from the computer-generated report. In the computer-generated report, there's a third paragraph that doesn't exist in your report. And the third paragraph that does not exist in your report says, with respect to negative impression management, that's malingering, right? That's faking. That's another term for it.
I would definitely not characterize it as that. So someone who has a negative view of themselves, or there could be multiple reasons for negative impression management. I wouldn't say malingering.
But it's what they're reporting, and it's a way of trying to determine whether or not their information is accurate.
Correct. It is part of the validity scales that helps us understand the method by which the patient responded.
Okay. But the paragraph that is in the computer-generated report based on the data that is not in your report says, with respect to negative impression management, there is no evidence to suggest that the respondent was motivated to portray himself in a more negative or pathological light than the clinical picture would warrant. Do you agree with that?
If that's from what I had given you, the computer, right? So the computer picks up on different methods of responding. I believe also it might have said the same thing about positive impression management. So again, it's interpreting scale by scale.
Okay.
But if it was in what I gave you, then it's what I gave. It's from me.
I understand. And I understand that it would make no sense to take the entire computer-generated report and put it into your own report. I understand that would make no sense, and that your report is a summary, essentially, of all the data that you've looked at, right?
Correct.
Yeah. But I just want to ask about a couple of things that are in the computer-generated report that I don't see in your own report. And again, the computer-generated report based on the data, part of it reads, a number of aspects of the respondent's self-description suggest noteworthy peculiarities in thinking and experience. It is likely that he experiences unusual perceptual or sensory events, perhaps including full-blown hallucinations, as well as unusual ideas that may include magical thinking or delusional beliefs. And that part, that's not in your report, right? That's in the computer-generated report.
Again, if it's there, that's what the computer. But I wouldn't be surprised, because that is absolutely how he was reporting symptoms.
I'm not trying to test your memory or play gotcha. I'm just trying to point out that these are in the data and they're not in your actual.
Okay. I confirm anything that I gave you as being part of the report.
Okay. And the computer-generated report also says that the patient may be involved in a wide variety of activities in a somewhat disorganized manner and may experience accelerated thought processes. And then at the end of the computer-generated report is a section that's entitled DSM-4 Diagnostic Possibilities, right? And that's the computer using the data to make its best guess at this patient based on the information provided in their testing, right?
Correct.
And these are suggestions. This is not a doctor evaluating him, but it's the data that you say that you rely on and that you believe in.
Based on this measure, yes, and rarely do we use what the computer is printing out as. I mean, we may or may not go with any of those diagnoses, but yes, you're absolutely right. It's based on the data that was put in for that particular assessment, correct?
And this is data that you believe in these tests, right? You believe in the data.
I believe in psychometric properties. So, and I think I know where you're going. So in terms of the method of responding, I think the validity indicators, which, like you said, there was one piece of the report that said negative impression management was not found, but there's also another part of the report that might contradict that within it. So
the positive impression management, is that what you mean?
mm-hmm.
Okay. And that's masking. Is that true? Trying to make yourself look not as bad as you
In
might.
particular areas.
But going back to the computer-generated report based on the data that you input for Tim, there's a section that talks about diagnostic possibilities, and it says the DSM diagnostic possibilities suggested by the configuration of PAI scale scores include delusional disorder, bipolar disorder, and schizophrenia paranoid type. Do you remember seeing that?
Yeah, I'm sure it did. That's how he was responding. Yes.
Now, if your data, you can do the same for the MMPI too, right? You can take the person's scores, put them into a computer-generated program, and it will spit you out a report, right?
Yes. I don't know if I have the interpretive report. Did I give you a report for this case? I'm not sure what.
I have one. I don't see your name on it. I see. It says date assessed February 22nd, 2019.
Okay.
But this shows the test scores or responses that Tim gave to you. And I've looked at, this one for the MMPI was long. What's 567 questions? Does that sound right?
Yeah.
I've looked at these and at your raw data and seen that the scores on here are the same as your raw data.
Okay.
Does anything else affect the computer-generated report other than just the raw data of the answers given? I have
The validity of the testing, so those built-in validity scales, and specifically for the MMPI-2, it can do a corrected scoring based on the patient's response pattern. So in this case, we did have a tendency of over-reporting symptoms. So sometimes it will correct it to some degree. There's different scales used. The MMPI has become increasingly complex with additional scoring criteria and methods by which this computer, when I learned it, we did paper and pencil scoring. Everything we had to do, we did on our own. And so, as the years have gone by, they've developed all these different criteria for scoring. So when I did the most basic type of printout of data interpretation in this one and utilized that. And that's of course, that makes sense scientifically in terms of what's been backed and supported for the most years versus some of these new scoring techniques.
And you and I talked about how complicated some of these tests are.
No, my report would be thousands of pages if I did that.
But you and I talked about the tests.
Oh, I'm sorry, I misheard you. Yes, we did.
Yeah. And I know that you testified when you were talking to the solicitor about how they can't be found online and just taken by lay people. But you and I talked about how I found one and I took one.
You told me you found the Sims in German and translated it after spending several hours doing so, and you took it and had a significant score.
Yeah, I know. It was interesting. I learned a lot. And we talked about some of my answers to some of the questions and how I and I think other people might read the same question and interpret it differently, right?
Correct.
Going back to the MMPI, the computer-generated report that I have that is based on the scores that were input based on Tim's testing. And I understand this is just the computer-generated report. I'm not trying to say that you said this, but it says that based on the profile, a severe psychological disorder is reflected. Client might suffer hallucinations, blunted or inappropriate affect, hostile and irritable behavior. May have difficulty managing routine affairs, poor memory, concentration problems, and inability to make decisions. Endorsement suggests the presence of delusions or hallucinations. He apparently believes he has special mystical powers or a special mission in life that others do not understand or accept. Apparently holds some unusual beliefs that appear to be disconnected from reality. Might experience unusual symptoms such as delusional beliefs, circumstantial and tangential thinking, and loose associations.
Is there a question?
I want to know, do you agree that these are things that could exist in the computer-generated report? Based
So I would be surprised if that didn't exist in the computer-generated report. Not only for that, but I bet on the MCMI, I bet you have another one that also says the same thing as you do with the PAI, because this data is all consistent across the board. So it's actually helpful that you're pointing that out. As we said before, the validity testing I did shows that he has a tendency to, a goal-directed tendency to report symptoms of psychosis beyond those experienced by populations with found psychiatric disorders. And so in self-report measures such as these 3 tests I gave, I would expect him to be reporting those symptoms. You're reading a computer-generated report that says, okay, so this person responded to 3, 12, 17, and so. So this is what we find from that in terms of the person's response style. So as the doctor, I have to make sense of all of this information. So when I find that in that area in particular, he is not a valid historian, I cannot put that into my report because that is not accurate data that I can support based on my testing. Now, we're not seeing over-reporting in areas of other disorders. We're seeing over-reporting in areas or reporting of such in this one area that you're continuously pointing out. And that's the area that I found him to be an unreliable historian in. So if my testing did not have that, I would have to explain that process. I would have to, I probably wouldn't have made such a big deal of the validity testing in the beginning because it would contradict itself. So this actually supports the testing I had done before this.
Yeah, I'm not trying to say that you're saying these things. You understand that. I'm not trying.
Right. You're just saying what the computer is saying. I just want to make sure psychometrically that the jury is understanding of where that information comes from.
Yeah. Well, I've tried to make it clear that this comes from the computer. But
Okay.
It comes from the computer based on the data that was input from the test, right? It's not just
Right, based on the defendant's self-report, yes.
So just going through the tests that you gave to the Sims test, that is solely a malingering test, right?
That's what it's used for, to gauge effort responding. Mm-hmm.
Solely a malingering test, trying to tell if somebody is faking, right?
Correct, to see the effort they're able to put in to see if they're over-reporting symptoms.
Right. And that's the test where you said that you felt that Tim exaggerated psychotic symptoms. Is that right?
Correct. That test in particular looks beyond psychosis. So that's when we would give for patients that we might want to ensure are not over-reporting cognitive symptoms as well. So in traumatic brain injury cases, I might give that test where there's no report of psychosis, because that test also has elements of intellectual ability and other properties that someone might over-report or under-report on.
And the SIMS test has a built-in number that's accepted by people in your profession as to sort of the level at which a person is likely malingering. If they get a certain score, they're likely malingering. If they're below that certain score, they're likely not malingering, right?
Correct. So for each subscale and also a total score.
Okay. And the total score, try to make a determination as to whether or not somebody is malingering based on the SIMS test, is 16 or above, right?
Correct. He scored below that for a total.
A 12, right?
Is that again?
Oh, yes. My apologies.
And the dot counting test, he wasn't trying to fake good or bad on that.
Correct. He performed within normal limits.
The Ray 15, he was not trying to fake good or bad on that.
Correct.
The second Ray 15, not trying to fake good or bad on that, right?
Correct.
And then again, on the SIMS test, you believe that the scoring shows exaggerating psychotic symptoms, but on the totality of it, he scored a 12, 16 and above is malingering.
Correct.
On the SIRS, or do you say SIRS?
The SIRS.
SIRS. There was 3 things that indicated to you possible malingering, right?
Right. 2 that fell in the probable range and 1 in the definite range.
And then there were 5 other parts of that test that showed no malingering at all, right?
Correct. Well, I should just to be clear, 2 were in what we would say a category of indefinite. I'm sorry, yes, and 3 were in the honest range. So, but essentially, right, subclinical. I wouldn't make anything out of any of them.
5 not malingering.
Correct.
3 that were indicative of some degree of malingering based on the test.
Probable indefinite. Correct.
I need to go back to the MFAS, but I just want to go through with the other ones beforehand. The Trails A, nothing indicating faking good or bad in that one, right?
Correct.
Nothing indicating faking good or bad in Trails B, right?
Correct. And those we would not be able to extrapolate an attempt to exaggerate or perform well. And that's a test of cognition. That gets into more of the more straightforward testing. So he performed in the 80th percentile on those. But no, he provided, on any test of cognitive measure, he provided full effort and performed very well.
Which tells you he's not trying to fake good or bad, because he's trying.
I found no indication he was trying to engage in any type of negative impression management, malingering of cognitive dysfunction at all. He provided excellent effort and worked consistently throughout all of the neurocognitive testing.
And then no indication that he's trying to fake good or bad in the controlled oral word association from multilingual aphasia examination.
Very good. Nope, he performed in the 79th percentile. It's very excellent for executive and verbal organization and ability.
And nothing to indicate he was trying to fake good or bad in the Luria complex motor exam, right?
Correct. The Luria Complex Motor Exam looks at motor abilities, visual spatial follow through, again, another task of cognition, and he performed without difficulty.
Same with the WCST-64, right?
The Wisconsin card sort test, yes, that's another one for executive functioning within the neurocognitive testing domain, and he performed within normal limits there.
Meaning not trying to fake good or bad, just trying hard.
Correct.
Right? And same with the test of premorbid functioning, right?
Correct.
And same with the Kaplan-Baycrest neurocognitive assessment test, right?
Right, and that's a very long test with multiple subtests and, again, appropriate effort.
And all told, we're talking about probably over 1,000 questions with all the tests combined, right?
Oh, at least.
Right, because one of them is 567.
Right, if you look at all the testing across all domains, correct. And just to clarify, they're not over 1,000 questions of true false. So he's talking about all the ones we did together as well. The neurocognitive testing is very much interactive with me timing performance and things like that. But in terms of questioning and persisting through testing all day, absolutely. It was a demanding day.
Yeah, sure, for both of them. Your Honor, may I have just a moment, please? May the solicitor and I approach?
That'd be exhibit 104. Court's exhibit door, what's the next one?
I just need to get one.
The next one, 104.
It'll be 104, court's exhibit, when Mr. Secor's gonna hand you a packet of the data from the testing that she did.
Yeah, and I,
Okay.
Okay, go ahead.
I can do that after the state's redirect if they have.
All right, redirect, solicitor.
Yes, sir, just a few things. Dr. Kruse brought up about, it was mentioned that Dr. Brawley had determined that the defendant, when she studied his brain, did his cognitive testing, that she attributed, whether or not she attributed his function to drugs or whether it was a brain injury. What is your knowledge of her report?
Within her report, my memory is that she had said that while some of the testing effects in terms of the impairment overall could have been due to the geodone, which was at 320 milligrams, twice the recommended dose from the FDA, she felt that that did play a role, but did not explain in entirety the difficulties he had. I think she then surmised it was due to underlying neurocognitive impairment from the brain injury or otherwise. I don't know. I haven't had the opportunity to speak with her.
Did you reach an opinion to a reasonable degree of scientific certainty as to whether the defendant, Tim Jones, has neurocognitive damage or any clinically significant neurocognitive impairments?
I did, and I do not believe he does to a reasonable degree of medical or scientific certainty.
And what do you account the difference between your test and Dr. Brawley's testing to be?
The effects of the medication, geodone, with psychomotor slowing and neurocognitive depression.
Now, you were questioned about the testing you did, and I'm just going to call it psychosis testing. You had SIMS, which is, you look for malingering, you had SIRS and MFAST. I believe it was mentioned that on the SIMS test that there was a total score, but when you and I talked, you picked out a subscale. Are there, in SIMS, there are a number of subscales, are there not?
There are.
but only one specifically for psychosis, is that?
Correct.
And that's the one where you found what?
He scored 6, with the clinical significance being anything over a 1.
That would be malingering?
The test says highly suggestive of a malingering disorder. Mhm.
And what is malingering?
It's a goal-oriented, voluntary, conscious, self-directed behavior aimed at exaggerating symptoms or creating symptoms that do not exist.
The two other tests you gave, the SIRS and the MFAS, were they also consistent with your findings in the SIMS?
Correct, they were.
Did you reach an opinion to a reasonable degree of scientific certainty as to whether defendant Tim Jones suffers from a psychosis?
I did,
And what's your opinion?
and I don't find evidence of an organic psychosis.
No schizophrenia, no schizoaffective disorder.
Correct.
Personality testing that you were questioned about, all this computer-generated stuff, that was generated from his responses, right?
Correct.
So the hodgepodge I was talking about, is that kind of like him going through a grocery store, just pulling things off the shelves?
Correct.
Throwing it in his buggy? And the computer, if I heard correctly, you said if it had to analyze that, he could have all these variety of symptoms,
Correct.
but it seemed to be goal-directed towards psychosis.
Yes.
And you have to go in as an expert to weed that out and see what he really has. Is that correct?
That's correct.
And you call that what again, what you do?
I'm a clinical neuropsychologist.
Right. And is there a method you go through? You don't just rely on a computer to do your work, do you?
No. We use psychometrics and neuroscience and brain-based behavioral patterns.
That's what I was getting at. And so when you went through to determine what his real personality issues were, did you reach an opinion to a reasonable degree of scientific certainty of a diagnosis for Mr. Jones?
I did. It was unspecified personality disorder.
And the traits for that unspecified personality disorder were what?
Primarily antisocial and borderline traits.
Now, it was also brought up that you did not write in your report just an official diagnosis,
Correct.
but you had a diagnosis. Is that correct?
Correct.
You didn't write a report out the way I would normally see one or another attorney because you were writing it for Dr. Friars.
Right. So you write reports for your audience. If I were to be asked to write a report for the jury, for example, I would certainly use different terminology and explanations with the assumption that they are not trained neuropsychologists, to my knowledge. I mean, maybe there is one, but I would write it differently. And so, of course, knowing I was writing this for Dr. Frierson, that guided my methods.
As to malingering, as to psychosis, did you also reach an opinion to a reasonable degree of scientific certainty as to that?
Yes. Hopefully I made it clear. So there's a preponderance of evidence supporting that there is a reasonable degree of scientific certainty to assume that malingering does play a role in the presentation here.
Thank you, Dr. Kruse.
Just briefly.
Briefly.
The test that the solicitor keeps talking about is the SIMS test, right?
Yes, we have discussed that several times.
And that's the one where you said the testing indicates exaggerated psychotic symptoms, or
In the one domain, yes.
the totality of the SIMS test says he's not malingering.
It did not meet the cutoff for malingering, correct?
Because it was 4 below the cutoff, his entire score.
The total, correct. It was 12 and the cutoff is 16.
16 and above is malingering, 16 and below is not. That's the cutoff.
Correct.
And when you met with Tim and were conducting these tests, he wasn't exhibiting psychotic symptoms to you at the time.
No,
He seemed to be cooperative and trying to do everything that you asked him to do.
he was very cooperative.
Can I have one follow-up?
Y'all had enough.
All right.
Both had 2 shots at her.
All right. That'd be fine.
Because if you get one more, he's going to want one more. So y'all both had 2 shots, and that's been fair.
That's fair enough, Judge. I'm good with that. Thank you so much.
Thank you.
Bruce.
Thank you.
You can step down.
Yes, sir.
All right, well, Scott.
Your Honor, we move to incorporate Dr. Frierson's testimony as to reply to Dr. Dorney's.
Okay, fair enough. You do that.
And
Replay is.
No, they're incorporating just by reference.
at this time, the state rests.
Very well. All right, I'll step in the jury room. It'll take about 15 minutes. I'll be back in here shortly and I'll find out what we're gonna do next, okay? So don't discuss the case, have you right back out here. Yeah.